neonates. I believe we were around here, correct? We're talking about bradycardia.
Looks right.
So bradycardia, right, in neonates is dangerous. Are they have a higher heart rate than we do, so they should be like little hummingbirds. So we want to make sure that we can correct this. The good news is bradycardia in the neonate is relatively easy to correct and doesn't have much of a long-term problem if it is corrected. So you want to make sure that you're appropriately ventilating these patients, these babies, that you're not overdoing the suctioning, and if you are doing some sort of advanced airway procedure, that you're cognizant of the fact that it might stimulate that vagus nerve. This is why we generally try not to tube babies, because you don't want to take out their heart rate. In terms of premature respiratory distress and cyanosis, prematurity is the most common cause of this, because their little tiny lungs aren't fully developed, and the neuro center for respiratory control is also not fully developed. So they're a little bit of a disadvantage in that department. Other issues that might cause this are a bunch of birth defects. So you might have like a fistula between the tracheus and the esophagus. You might have baby might have pneumonia. There might be some sort of like a failure of the fetal circulation to start correcting itself. So there could be a whole slew of different issues, most of which you aren't going to necessarily fix, but we can ventilate, so that's ideal. Having issues. Hypovolemia, okay. Neonates, generally when they're first out, the biggest concern that when it comes to like within the first few hours of life and hypovolemia is that there is some sort of level of hemorrhage, or that they haven't fully, they experience some sort of trauma in the womb. They might be dehydrated. Sepsis is always a possibility, but is usually more on the rare side because they're benefiting from mom's immune system. But remember that you aren't going to have a very accurate blood pressure reading in young children. Um, they're going to maintain their blood pressure for a very long time before they fall off that cliff. So it's not necessarily accurate to determine whether or not, the patients are in shock. You have to determine that the patient might be hypovolemic or in shock due to other signs and symptoms, such as pale skin, cool temperature, your color temperature condition. Capillary refill is very accurate in young. Excuse me. In terms of seizures, neonates they don't necessarily experience febrile seizures as the same way that young children do. They are always considered pathologic. You want to make sure that you're containing or controlling these seizures and making sure that the baby is ventilated appropriately. Most of the time, prolonged seizures in the neonate is a sign of like a cardiopulmonary issue or a metabolic change. Okay, so babies who are born to diabetic mothers who start having hypoglycemia, right, because they don't control their blood pressure proper or their blood sugar as effectively as born to not diabetic moms. So they might tank their blood sugar. A close eye on that. In children, they don't use benzos as the first line; they use phenobarbital, but we don't carry phenobarbital. But you do want to make sure that their blood sugar is in an appropriate range. Fever, okay. Your rectal temperature in babies is going to be a little bit higher because they have a little bit higher metabolic need. Okay, so you want to make sure that you're in or out an infection. Neonatal sepsis is a thing, but again, it's rare. Mom's should be helping. It would be really if mom had an infection that she shared with baby. Hypothermia we talked about again also. Core temperature less than 95 degrees. Um, might be due to either a decrease in heat production or an increase in heat loss. Remember that neonates and babies in general have a greater body surface area, okay, and very easily lose heat to the environment. This is why we bundle babies up nicely. Potatoes, because they aren't unable to shiver and maintain body heat as well as adults. There's also the possibility that hypothermia is secondary to sepsis, so you want to make sure that you ask the appropriate questions um, of mom if she's had any infection recently. Usually, all right, so hypoglycemia in the newborn is usually less than 40, okay, so they get a couple extra points of range as opposed to adults. If the baby is a preemie, they can be all the way down to 30 before that's considered hypoglycemia. A number of different risk factors. Again, mom who has diabetes is probably one of the highest levels of risk factor. Um, if the baby was a smaller twin or any other number of things, you might not be able to fully kind of understand if the baby is hypoglycemic, right? Their baby's not going to start acting confused, but they might act odd. So any sort of twitching, seizures are always a very suspicious sign of uh, hypoglycemia. Um, crying, not breathing properly, cyanosis. Just make sure you get a blood sugar. Vomiting, diarrhea. We definitely did most of this. Skip ahead. All right, so units are highly susceptible to infection because of the diminished immunity, but if they are super fresh, they still should have some level of mom's immune system support. Breastfeeding also helps protect baby, to a certain level. But viral infections are very, very common. RSV is one of the most commonly seen viral infection. It's a respiratory syncytial virus. Okay. Um, a baby who is septic might not look septic, right? They might just be a little off. They're not acting normally, and mom doesn't necessarily know why. If they have temperature instability, right? They have a fever, they're cold, they're all over the place. They're not breathing um, well, or mom or dad just doesn't think that the baby looks like their normal self. Um, common birth injuries always a possibility also, especially if the baby has a larger head. Okay, most common is the clavicle fracture. Right, there is a possibility of other issues. Excuse me, such as intracranial hemorrhage. Okay, a lot of these things can also like lead to stuff. Asphyxia or hypoxia can lead to things such as cerebral palsy. Um, baby might have various cranial injuries. Okay, depending, you know, not only if they get stuck, but if um, they use suction to pull the baby out, with a odd-shaped head, or skull fractures or other problems. Remember, babies are kind of squishy, so not a lot of stuff protecting them. Make sure that there's no that needs to be addressed. So congenital abnormalities also exist. Remember, there was a thing that they were talking about microcephaly when babies were being born with itty bitty heads. Down syndrome, okay, or trisomy 23, another congenital abnormality that's very common. Other issues can be caused by maternal infection and drug or alcohol use. There's some research coming out that they believe that autism is linked to maternal inflammatory response during pregnancy. So, like if mom gets a really bad infection, has an inflammatory response, then more increased risk of the child having autism. Okay, that first trimester is usually the most important in terms of development, but at this because the baby's poorly protected. But at the same time, a lot of women don't even necessarily know that they're pregnant at that time. Um, dangerous times there. Uh, so atresia, or any type of atresia, is a failure of a passage to open. Okay, so you might have try to say this. Uh, this version of atresia where there is no opening between external environment and the nasal passages. Um, so the baby isn't going to be able to breathe because remember, babies are kind of obligatory nasal breathers. They don't really understand that they can open their mouths and breathe. So basically, they don't have an open nose passage. um, so it might be fully blocked or just partially blocked. Excuse me. So things to consider. Um, you might have to ventilate this baby. Okay. Um, there's the possibility of a tracheoesophageal fistula, where a hole opens up between um, the there's two different types where one either a hole opens up between the esophagus and the trachea, or the esophagus doesn't actually have an end and it only has and the other end opens up into the trachea. So the baby can't swallow properly because it's not getting down to their stomach, which leads to high risks of pneumonia, right? Aspiration pneumonia, choking, um, all sorts of other issues that needs to be surgically repaired. Cleft lip and palate, pretty common. So basically, that palate on the top of the mouth doesn't close properly, so the baby has this big gaping hole, which can lead to food ending up in the nasal passages. Failure to thrive because they can't make a proper closure, right? There's a whole cruise ship that goes around the world and does cleft lip, palate, and cleft palate repairs because there's very poor outcomes if it's not addressed. And there's lots of third world countries that don't necessarily have the plastic surgery abilities to fix this. So it's a lot of repair that needs to happen for this baby so that they can thrive. Pierre Rod sequence, the baby's born with like a chin. I just love this picture. It's really hilarious. He looks like a bad French painting. So there's a number of congenital anomalies that pop up. Basically the biggest problem is the baby has a very small mandible, and that small mandible pushes that tongue backwards, creating an airway obstruction. The baby has a difficult time feeding, okay, and a lot of other problems with the congenital abnormalities could include like poor blood flow to the brain, pulmonary hypertension, heart failure. Again, not a lot that you're going to necessarily be doing for this. It might be a challenge to ventilate this baby if you have a mate in the field without a diagnosis. But for the most part, like these are going to be babies who might be doing transport for like a interfacility transport. These are important to know. These are your tetralogy of Fallot abnormalities. Um, there's three different types. Most of the time, will you hopefully won't see these. Um, most of the time, if you are delivering a baby and you have patent foramen ovale or patent ductus arteriosus, the baby's not going to pink up as quickly as you expect, and they can either wait to see if the ductus arteriosus closes, and or they'll go in and do surgery to repair it. With coarctation of the aorta, you have a serious slowing of the segment of the aorta. Again, that's going to need some sort of being addressed. The tetralogy of flow, however, the bad part of it is you're having blood mixing. The good part of it is that the way that it's overridden, right? You just because you have mixing of blood in a neonate, if you didn't have all of the mixing of blood, the baby wouldn't do it, if that makes sense. Oh, there we go. So these shunts that exist are what kind of maintain that oxygenated blood flowing through the body, even though it's still mixed. Okay, so basically what happens is if you have a failure of the fetal heart to either properly develop or properly have those, holes in the heart and the fetal circulation dissolve, the blood will mix, and then you have an over enthusiastic left ventricle. Okay, so you're just not doing a very good job of circulation. Babies usually end up requiring open heart surgery to fix the issues. Um, so a left to right shunt is you have oxygenated blood going to the right side, and being oxygenated again. So you're overloading the pulmonary system. And coarctation of the aorta. The aorta gets constricted at some point, usually just around that curve, which means that the head and the arms are getting good blood flow, but downstream, like to the kidneys and legs, less so. So you might have a baby who's kind of pinkish up top and a little less or more cyanotic in the bottom, like a baby mullet. This causes the left ventricle to have to work a lot harder because it's trying to push past that narrowing. You have septal defects. That hole could be either between the atrias and the ventricles, or atrias or the ventricles, or it could be both. People or excuse me. Septal defects might be asymptomatic, okay, where like they're so small that, or atrial septal defects might be so small that it's kind of asymptomatic. Most of the time, the ventricular ones are more noticeable, and it will lead to like an overloading of the heart because of that mixing of blood. You're going to be doing about it at the hospital. A lot of times, a lot of these things, they might already know that the baby has an issue. Just in so much as they picked it up during sonograms, and they know that the baby's going to be needing surgery after birth. Pet and ductus arteriosus, right? So the blood's coming from the aorta and flowing right back into the pulmonary circulatory system. So you're oxygenating oxygenated blood, which decreases the overall systemic oxygenated blood flow. So these babies are going to fatigue very quickly and grow slowly if it's not corrected. Truncus arteriosus, there's a large ventricular septal defect, so that one great vessel arises. So there's no real differentiation between the aorta and the pulmonary artery. It just becomes one big artery. So there's a lot of excessive blood mixing, and the baby will show signs of heart failure very quickly because it's just not effective. Baby won't be able, child, if it's not corrected, will have extreme shortness of breath, decreased exercise endurance, dizziness, like syncope, stuff like that. So valvular defects, you can have stenosis or you can have regurgitation. You cannot have both in the same valve, okay? And that was brought to you by a cardiologist because I had asked, because I had a patient once who's like, I have stenosis and regurgitation, and like they're like, yeah, that doesn't exist. It's one or the other. Stenosis means it doesn't open properly, so you have a very narrow opening, whereas regurgitation doesn't close properly, so you have this leakage. Okay, so you have just your issues of one or the other. Most of the commonly mitral and aortic valves are the ones that are being affected. I think it's something like 80% of females in the world have a certain level of mitral regurgitation. It's just a normal thing where the valve doesn't 100% close properly. Um, if the valve is stenotic, it doesn't open all the way, which means it's forcing blood backwards. If the valve is incompetent and regurgitates, it doesn't close all the way and is regurgitating into the chamber. Every once in a while, a tricuspid valve or pulmonary valve doesn't become created during fetal development. Um, or it's completely closed, creating all sorts of fun problems. Um, blood flow doesn't go where it's supposed to. Just remember that atrasia means that it's not open. Okay, so if a valve doesn't exist, it doesn't. There's no blood flow from either the tricuspid or the pulmonary side. There's really nothing that you're going to be able to do about it. Hypoplastic left heart syndrome, you have very small left ventricle. Okay, a lot of these issues, it needs to be that fetal circulation still exists for this child to survive before it's addressed. Okay, so that fetal circulation won't necessarily close. Closing the fetal circulation can be deadly to the child. Good news, you won't be personally closing the fetal circulation. um, so you just want to make sure that you keep the baby calm. You should know tetralogy of Fallot. There's almost always a test question on it. The other ones, not so much. There are 4 components of tetralogy of Fallot. That's why tetra is 4. So 1, you have pulmonary stenosis, which is a very stiff and thick outflow tract to the lungs. Number 2, you have a very thick right ventricular wall, so it's not pumping effectively. Number 3, you have a ventricular septal defect, which means that you have most of the time the ability of that blood to be mixed. And 4 is the aorta overrides the septal defect, which means the aorta is living right over where that septal defect is. Collectively, this allows the baby to survive due to the mixing of blood. They're not going to oxygenate well because the blood flow to the lungs is limited. And this is definitely something that it ends up, the baby's going to need surgery. Here's the actual breakdown. So the ventricular septal defect allows oxygen blood go to the right ventricle, or get to the right ventricle. And the pulmonary stenosis means that the heart has to work harder. The right ventricle starts to get larger because of that excessive work, and then the aorta gets both deoxygenated and oxygenated blood. The baby's not being collectively not being oxygenated properly, but without all of the placental failures, the baby wouldn't survive either. Most of the time, babies who have tetralogy of Fallot will, when they start crying or they're eating, they will start to turn blue and cyanotic or have what's called tect spells, which is when they start having, they sort of pass out and turn blue. Now that we have better medicine, most of the time these babies are kind of found and treated before this starts to become an issue. Then you have the transposition of the great arteries, where the aorta arises from the right side of the heart, and the pulmonary arteries arise from the left side of the heart, meaning that we're sending oxygenated blood right back to the lungs. Okay, so it's just oxygen is on one side and the deoxygenated side's on the other side. The only way that these children will survive is the prolonged presence of fetal circulation. So that mixing of blood, allowing sort of deoxygenated blood to make it back to the rest of the body. As this baby's good job oxygenating because nothing hooked up quite right. And you can have this other delightfulness where the pulmonary um, arteries are not connected to the heart. They're usually connected to the superior vena cava, so there's a lot of blood mixing yet again. Um, Again, these are babies who are sick and probably won't be leaving the hospital until they have heart surgery. Um, they might present poor upon being first born, but hopefully very quickly. Congenital heart problems is if displacement of the AV node of the bundle of His. Okay, so they're going to have AFib or aflutter and reentry. Might have some heart blocks. Okay, so just things to look out for. Because again, intestinal malrotation. Okay, so if the baby's born and has intestines start twisting, they'll usually twist around the mesenteric artery during development, which leads to serious bowel obstruction and a decreased tolerance for food. So they might have diarrhea and constipation. They might have vomiting. Okay, all sorts of other stuff. They need to go in and surgically fix this because it's all twisted wrong. Pyloric stenosis is very common in infants. The muscles are a little overdeveloped and can cause intestinal obstruction, which then usually will end up with like symptoms of GERD because now it can't, the stomach acid can't go down through the pyloric valve or pyloric sphincter, so it comes up the other way. Baby usually have like a lot of vomiting because they can't empty their stomach. Okay, usually accompanied by dehydration, and as I said, GERD. You might see diaphragmatic hernias every once in a while. The diaphragm isn't properly developed, so the abdominal organ starts going up into the chest cavity, usually on the left side because that's where the hole for the esophagus is. It's usually where the failure of the diaphragm to develop is. So you'll end up with bowel sounds in the chest and a very flat looking stomach. Baby will have respiratory distress pretty immediately after birth. This is when you have to kind of sit the baby up to encourage the intestines and abdominal organs to go back into the abdomen. So here's a picture. Their heart sounds might be off to the side. They might not have good breath sounds on, again, usually the left side. In the hospital, we don't do OG tubes, but they can use an OG tube to decompress the stomach a little bit to improve ventilation in that left lung. Excuse me. This is not a child who you should be ventilating because the possibility of gastric distension is going to make it significantly worse. Gastroschisis. Basically, there's an opening in the abdominal wall, the intestines and other organs come out. It's usually to the right side of the navel. Okay, you treat this as an evisceration if this happens to occur. Basically, the stomach didn't appropriately develop, as opposed to I can't. Whatever this one is. It's the same concept, except rather than next to the navel, it's coming out around the umbilical cord. So this is, again, you're going to treat this as very carefully as like an evisceration. There's a possibility that this could rupture, so you want to make sure you're very gentle. So spina bifida. Spina bifida is one of the things is this is why they promote uh, prenatal vitamins that contain folic acid. This greatly reduces the incidence of spina bifida. So basically, there's different levels of it, but the whole thing is that um, the spinal cord extends itself out outside of the vertebrae, the protective vertebrae. So you have an exposed portion of the spinal cord because either the spinal cord didn't develop properly or it goes around. There's like coma versions. So there's another ways, but this is why they encourage women to take folic acid. Because obviously you don't want to touch that piece of the spinal cord. That's going to be an issue for different levels of severity. So this looks, you know, gruesome because the neural tube closes outside or with the spinal cord outside. It could be worse. The baby might end up with some paralysis or other numbers of issues. Fine a bit. Questions, thoughts, concerns. Trying really hard not to. All right, cool. Questions to pediatrics. So kids are not just little teeny tiny adults. They have very unique anatomy, physiology, and psychological characteristics as they start growing up. Take this adventure together. So what newborns? Newborns are less than 1 month old. Okay. We just talked about a whole bunch of these things, so we're not going to go about it over and above. Um, but respiratory problems are really your number one concern, right? Because they have very little, teeny, tiny, incomplete lungs. Vomiting and diarrhea is always a concern because they tend to dehydrate very quickly. Jaundice, um, fever and sepsis again because they're not particularly well um, protected. Their immune system is a little underdeveloped. But now we can move into the infant stage, right? So they move closer to that 1 month range. They'll start being able to do more things. Babies are able to hold their heads up relatively quickly, right? Because they want to be able to look around and engage with their environment. Unfortunately, babies are also not 100% able to communicate, right? They do a lot of crying. So if the caregiver tells you like this crying isn't right, then you need to respect that and you need to understand like, yes, this person probably knows what they're talking about because this is their child. They grew it and then they're taking care of it regularly. So if this doesn't sound right, then this probably is correct. Um, Again, very similar in infants, the same common illnesses where you have like respiratory illnesses, GI issues where they might be hydrated, vomiting, diarrhea, um, sepsis, okay, and SIDS. SIDS is always a possibility, okay. Talk about that a little bit more in upcoming slides. Older infants, right, as they start getting into that, like, I start moving around and I start putting things in my mouth stage. Foreign body airway obstructions is always a possibility, as is physical injury, right? They start doing that thing when they start trying to cruise, right? When they're trying to learn how to walk, and they'll hold on to furniture and try to move around. And it's a good positive time for them to crank their heads against things that are sharp, like coffee tables or steps or whatever else seems to be going around. So, this is important that you keep in mind that there's a certain level of normalcy where babies get injured from falling, but you should also always have a high suspicion. Bronchiolitis and croup is also very popular in this age range. They have a very small airway, so anything next to that airway um, is going to potentially be very dramatic for that child. Toddlers, the demon age. This is when they start really developing a person, like a more significant personality, and they're much more mobile, which means that they're going to be much more rambunctious. If they are not being supervised properly, there's a lot of physical injuries that can, a toddler can sustain just from falling down flights of steps or hit by dogs or, you know, ingesting Drano or drowning in an unsupervised pool. A lot of different trauma issues that can happen. This is also when febrile seizures start to become a thing. Uh, Vomiting diarrhea is always a concern for any age range, for especially for diarrhea, for dehydration issues. Sepsis and meningitis. Okay, preschoolers. This is the age where they start advancing very, very rapidly. Not only when their motor skills, but their verbal skills. So they have a little uh, better ability to really kind of make their needs known. Um, they're very curious. They don't always have that stranger danger kind of feel, but they're going to start investigating things, which means that they're going to, and they're taller and more mobile and faster, which means that now they can get hurt more often. They don't really understand the concept of danger great. This is where parenting comes into play. This is hot, don't touch it, kind of things. Um, Drowning incidents always a possibility in the younger age group. Vomiting, diarrhea. School age, right now they are much larger. They might be experiencing the onset of puberty. They're still growing like rapidly. Brain is expanding, and they're learning a lot. But now you have the social issues that start to kind of sweep in, bullying and that urge to fit in. But they also can get the same kind of viral infections and injuries that younger groups can. Now the injuries are going to start getting a little more significant because they can do, things like ride a bike better or worse, depending, I guess, if they're going to get injured on it. They're a little more adventurous when it comes to trying new things. And they're of an age range where we start to think, oh, yeah, no, I can do that. That's fine. So adolescence, all right, this is where we start to transition into that adult stage. Um, your blood pressure and your vital signs start to meet that expected range of an adult, but you have a lot of other social issues, peer pressures, body image issues, um, increased risks of behavioral emergency like depression and suicide. But not only that, but you have the increased risk of behavioral issues coming to fruition. 19 is about the age range when the schizophrenia and other mental health issues start to show up. So, well, that influx of hormones can change the brain chemistry. Sexual assault in pregnancy is always a possibility in adolescence also. All right, anatomy and physiology. Up until about 8 years old, babies have what I like to call big old pumpkin heads. It's proportionately large. About 25% of the total body weight in newborns. They have a very small face, but a very big back of the head. And because of that big back of the head, that's going to change the way that you need to position them for ventilations and for breathing, right? Because that's going to close their airway off if it's too big. Anterior fontanelles remain open for about 9 to 18 months after birth. Okay, so they usually will close. It's the ones like right here. Okay, that's always a good sign or a good indicator on that right here, the anterior fontanelle. If it's bulging, there could be a brain bleed. Baby might be crying, which is totally normal. Um, or there might be hydrocephalus or some other issues going on. Um, or if it's sunken, that's a good sign that that baby is dehydrated. Pediatric airways are smaller, okay? They're much more narrow and they're much less stable than adults. They don't have that hard cartilage holding it open as much. And it is very, very narrow. The cricoid ring in the pediatric airway is the narrowest part of the airway. Because everything is a little bit smaller, like the jaw makes the tongue look proportionately larger. Um, it also, like the epiglottis, is also kind of a little less well defined and a little more floppy, therefore a little bit squishier, and can block the airway, which is why epiglottitis is so dangerous for younger children. um, respiratory rate, babies don't tripod necessarily. They try to lean back. They have a smaller tidal volume, but they have an increased metabolic oxygen demand, so they breathe a lot more. They don't have the same oxygen reserves that we do as adults, right? We talked about that in airway a million years ago, but that residual volume that's just kind of hanging out. So you want to make sure um, that you're very cautious with children who are having respiratory problems because they're going to get tired a lot faster than adults will. Uh, your cardiac output in a child is rate dependent. Okay, they aren't really able to really manage contractility and stroke volume as much because it's just an underdeveloped itty bitty heart. Um, they are also highly dependent upon vasoconstriction, okay, because they can kind of shunt really well. There's a lot less uh, vasculature for them to have to manage, so they can shunt it really well and bring it back to their core. But that also means that their vital signs are going to maintain normal ranges for a lot longer. If you look, an infant, a 9-pound newborn, has about 12 ounces worth of blood. Okay, that's a soda can worth of blood. So any amount of blood loss can be super significant for children. Even a 60-pound child, it's about 2 liters of blood. Okay, so you know that 60-pound child is probably what, 5 years old. Okay, so you want to make sure that you're kind of getting an idea of how much blood is going on inside the child, and so that they can like maybe not lose. I don't want to make sure they're not losing blood. While the nervous system is a little bit better protected because it's got a little more cerebral spinal fluid space with better buffers, they also have those open fontanelles, so any direct area or direct hit to those areas can be a devastating brain injury. Their spinal column is a lot more flexible than we have as adults, so they'll end up with stretching concerns as opposed to like a shearing damage. Young children don't have the same um, abdominal strength as we do, right? They don't have a six pack, unlike this kid right here who clearly has a six pack. So those little tiny baby muscles aren't as protective um, of those, internal organs. There's also all those organs are much closer together because they don't have as much space to live. Okay, like itty bitty living space. They don't. They're not as spread out as they are in adults, which means that if a child gets an abdominal hit, it's more likely that more organs are going to be injured. Um, the liver and spleen are also significantly more vascular. Chest and lungs, okay, again, bones still kind of on the squishier side. Um, very pliable. They're not angled the same way as our ribs are. Our ribs are kind of angled a little bit on an angle. The children's ribs are very horizontal, so it's not as, because they are squishy, there's not as much protection. And again, the muscles get tired very, very quickly if they have to have those chest muscles involved in breathing. Most of the time, they just use their diaphragm. So it's if they have to resort to accessory muscles of the chest to help breathe, they're going to deteriorate quickly because it's just not enough. Um, in the extremities, because children are expected to continue growing, they have what's called the epiphyseal plates or your growth plates. Any damage to the growth plate can cause serious complications, such as like one limb being longer than the other. Um, so if you are inserting an IO, you want to make sure that your placement is 100% correct because you don't want to be the cause of bizarre bone issues for that child if you do happen to rescue them. Um, kids' bones are still, again, just like we said, they're very soft, very pliable, so they won't necessarily fracture straight through like an adult bone will, but they'll have what's called green stick fractures, which I don't have a picture. Green stick fractures, the bone just bends and get kind of frays at the bend point. Um, so you want to make sure that even if you think that the kid is having has a sprain or a strain, that you should still consider a fracture and splint it, even not obviously broken, because if it's broken, you just aren't able to see it because of those bendy bones. Baby skins are much baby skin for children's skin is much thinner and more elastic. So anything that damages it can be much more lead to a much deeper injury, especially burns. So you know, as an adult, if you burn your skin a little bit, you might just get like the epidermis, as opposed to like a child might end up in a third degree burn. There's less subcutaneous fat, which means that they can't regulate their body temperature well. Again, this is why we bundle up babies. The body mass ratio is much larger in children, which is again why children lose heat so quickly. This is why we bundle them. They also don't have great glycogen and glucose stores as we do as adults, right? So they haven't had the opportunity to necessarily build up those glucose stores like we did because we ate a whole pizza the other day. So that means that their blood sugar is going to be a lot more unstable than it would if adult. Um, so you want to make sure that if you have a kid who is sick or is injured, that their blood sugar is in a good place. Um, in terms of blood volume, children can lose a lot of blood volume to vomiting and diarrhea. Okay, remember they're really small, so 1 or 2 episodes of vomiting or diarrhea can deplete them. It's 12 ounces of fluid that's floating around. Okay. They also don't have good shivering capacity, which is why we bundle them up so well. So, in terms of a pediatric assessment, how you assess in what you're assessing is going to depend on how old the baby or child is, how mature they are, what the level of physical assessment are, or physical development they are. Just like anything else, scene size up, right? You want to make sure that you're assessing this house effectively or this home effectively, that there's nothing dangerous laying around. It could be pills, medication bottles, chemicals. Um, is it clean, right? Do they have proper heating in the home or cooling? Is the home uh, there's a certain difference between like the home is a little bit of a mess because you know the parents didn't maybe vacuum that day versus it's a hoarder house, or there's open bottles and stuff like that. And then what's the interaction between the parent or whoever's caring for the child and the child, right? You can see a lot about a parent-child relationship based on how um, child interacts because the child's not going to lie. um, on your primary survey, right? Does the child move? Okay. Are they moving effectively? Are they, especially when they're at a stage, a developmental stage where they're not able to make their needs known with actual like language, right? Are they limp? Are they moving around? Are they alert? Do they look at you when you walk in the room? Um, if they're crying, are their parents able to console them? If are they looking at the caregiver or the paramedic? Are you able to get their attention? And when they cry or they speak, is there a um, strong sound to it, or does it sound weak and kind of futile? So this is part of the pediatric assessment triangle. A stable child has a good appearance, a good work of breathing, and good circulation to their skin. Once one of these doesn't look quite right is when you start to have an issue. So if they have, increased increased work of breathing, they're probably in respiratory distress. If they have increased work of breathing and they look like crap, respiratory failure. If there's poor circulation to the skin, could be shock. If poor circulation to skin and the kid looks like crap, shock. If they look kind of off, just metabolic issue, and all three are not doing well, going into arrest. Considerations for your airway, breathing, and circulation for the child or pediatric patient. That might differ a bit from adult. Okay, so secretions are going to be a little more significant a young child because they're a much smaller airway. Tongue disproportionately large, so you're going to have to make sure that you're managing that airway effectively. Grunting noises, right, might mean that there's some sort of obstruction or their tongue is in the way. But you want to make sure that you're not going too aggressive in your management because you can trigger a vagal response and take out their circulation. In terms of breathing, right, do they have good breath sounds? What's the pattern of their breathing? Things that you might see in a child, right, the nasal flaring is like then their nose gets bigger. If they are really young, they don't have a lot of extra capacity to expand their airway, right? So they're going to do whatever they can in making their nose larger, expand the amount of oxygen that they can get into their lungs. Accessory muscles, I always recommend that you pick up a child's shirt to look to see if there's contractions, to see if those accessory muscles are being fruited. Capillary refill is great in younger children. It's a good indicator of perfusion. Blood pressure really should be reserved for kids over the age of 3. Skin temperature, color, and condition, right? Turgor is a good sign if they're dehydrated or not, especially if they're little. You can pinch the skin on their scalp and see if it tense or not. And a visible hemorrhage, as always, is an issue. When obtaining a focus history, most of the time, for young children, you're going to be getting a history from the parents or a caregiver. Once they get older, you should be involving them in the assessment because they want to feel like they're grown ups, that they're being respected as well. School age kids and adolescent children are going to be able to provide the most information, but there should be a certain level of separation from the child and the parent. If you are having do feel that there's a need to ask about sexual activity, drug use, stuff like that. Obviously, that might not be a part of every single assessment that you perform, but if it is, asking those in private. Younger children, instead of doing a head to toe, we do the toe to head. Okay, to kind of get the kid comfortable with the idea of being touched by a stranger, and unless they, of course, are in some sort of serious illness. If they're in a level of serious illness, they will probably let you do a head to toe, okay, without having to get comfortable and warm up to you first. but depending on how sick the child is going to determine how deep you dig into this, secondary assessment. And I will tell you this right now, the number one question on the REMAC and the state exam when it comes to pediatric children is, what is your priority? Your priority is to go to the hospital. Okay, you're not going to be doing treatments, you're not going to be doing any of those things. Your priority is to transport. So do not waste time on scene doing, um, or finger stick. You should be doing everything in motion. Okay, that's the primary goal. Number one cause of cardiac arrest in children is due to respiratory insufficiency. BLS, BLS skill, right? This is BLS knowledge. You should be aware of this. The most common cause of children going into cardiac arrest is respiratory compromise. Distress is the most mildest form of respiratory compromise. Okay, you'll see this child working. They will be not good, right? They might be grunting, or they might be head bobbing. They might just be kind of irritable or anxious. Sometimes this is super simple to fix, especially if they're younger. You might be able to do some suctioning of the nose and like help clear that up really quickly. Otherwise, you might need to do a bit more work, a little bit more oxygenation, etc. Problem with children is that because they have no real residual volume in terms of they will go into respiratory failure a lot faster than adults will. Okay, so once that child goes from being irritable to becoming lethargic, that's a bad sign. Central cyanosis, bad sign. Okay, any of those things that you see, kids looking very unwell, all right? Very aggressive in that maintenance of the airway and ventilation, okay? Because otherwise they will progress into cardiac arrest and orthopedic arrest. But 80% of pediatric foreign body airway obstructions are in children 3 and younger. Okay, it's very commonly happens when unsupervised children with toys, or kids with food when they're trying new foods. Okay, hot dogs and grapes in particular. This is why you should always cut grapes into smaller sizes, because it's a little bit too big for their or their mouth, and it just goes down, right? Grape is slippery, so are hot dogs. Popcorn and peanuts also very common. Um, if the airway obstruction is only partial, you want to keep that child very calm and bring them to the hospital. Okay. If it's a full airway obstruction, successful with the Heimlich, no forceps is there. Any sudden onset respiratory compromise in an otherwise healthy child should be considered a foreign body air obstruction. This scenario shows up on the REMAC test every year. Mom says that the child was inside, was watching TV, and then all of a sudden heard a noise, a funny noise, and she came in and the baby was just not acting right and was having a hard time breathing. Okay, like the kid didn't get the flu in the last 30 seconds. It's most likely a foreign body airway obstruction. So always keep that in mind. It pops up in scenarios very, very commonly. Croup is very common. 'Tis the season for croup right now, late fall, early winter. It is very commonly a viral infection of the upper airway. And the child will have a low-grade fever, hoarseness, a very bark-like cough, bark seal-like cough, and potentially some inspiratory stridor. Most of the time, the kid is fine until you put them to bed, and then they have a hard time breathing. Okay, the best thing for croup is to bring them into a cool air, right? That hot air inside of a home is usually what triggers like that distress. Other possibilities of fixing, and you'll see, parents will move their child into the shower. This humidity in the shower will help open up the airway again. If they are moving into the airway obstruction realm, because of airway edema, racemic epinephrine should be nebulized. It's coming protocols is coming down. If you don't have racemic epinephrine, 1 to 10,000, I believe it's 1 to 10,000 diluted in normal is effective as well. All right, epiglottitis. Epiglottitis can happen at any age. It's just much more dangerous in the younger group because they have a smaller airway. Most of the time, kids who have epiglottitis are very, very still. Okay, they're focusing on breathing, and that's their main concern. As opposed to croup, which is viral, epiglottitis is usually bacterial, and it affects the upper airway, primarily the epiglottis. The kids will wake up with a sore throat, like a muffled, like that sexy voice, a fever, and drooling. A lot of the times, to test questions, drooling will be your clue that they're looking for you to think epiglottitis. Epiglottitis, you need to handle these children very, very carefully because they could go all the way to airway occlusion rapidly. Bacterial tracheitis is a rare but secondary infection. So usually the kid will have just gotten better from having croup, and then all of a sudden they are sick again. Upper airway, usually it's a bacterial a bacterial infection that it kind of takes advantage of the weakened immune system. Respiratory distress, pus and mucus in the cough. Might see some stridor. It's really bad. It can lead to airway obstruction, respiratory arrest. They don't commonly call asthma until the child's about 2 years old. Until that, they call it bronchiolitis. But because it's difficult to diagnose when they're young. Most of the time, right, we're asthma, and how asthma does, it's that restriction of the airways leading to wheezing. Because children have a very underdeveloped respiratory system, this could affect them much more because they don't have those accessory muscles really to participate to help bring air in. A lot of time it can be exacerbated when they're really young by exercise and allergies, changes in temperatures, stuff like that. Again, sometimes kids who have asthma, they won't even wheeze, they'll just cough. You just hear a cough. And mom will be like, yeah, he's been coughing all night. Nothing's coming up, it's just a cough. I have a high index of suspicion for asthma for kids who are just coughing. And especially if they're like, yeah, well, if my lady once, her boyfriend's dog came over and her kid, oh, he has allergies and he's coughing. And you listen to his lungs, he's wheezing. Okay? He's allergic to dogs. She knows he's allergic to dogs. She's like, oh, he'll just grow out of the allergy. I'm like, yeah, no, he's got asthma. Like this is asthma. But he's around that 2-year-old mark, so it's hard to get that diagnosis. Bronchiolitis, again, we talked about this a little. It very, very commonly shows up with as asthma in children younger than 2. Most of the time they will present with a fever, however, but there's not a lot of necessarily differences between the two. They may or may not actually respond to bronchodilators. Sometimes it will actually help them breathe a little bit better. Most of the time, bronchiolitis is caused by RSVs, respiratory syncytial virus. Pneumonia is, again, always a possibility. Patient might feel chills, right? Present with a fever, might have some wheezing, they might crackling, they might have shortness of breath. They might just overall not feel well. Pops up, okay, a number of different times. Kids who, maybe are playing outside in summer or going in the pool might suck in some water in their lungs. They might get pneumonia from that. Pertussis, okay, or whooping cough. This is very deadly for younger children. It causes inflammation of the entire respiratory tract. Um, and they will go into these sessions of like just coughing, okay? And they cough so aggressively that they can't get air in. This is why it sounds like that whoop sound. Um, Other complications are pneumonia and apnea, especially in young children. There's the pertussis vaccine that they actually highly recommend that everyone gets before they come in contact with the newborn because it is so deadly. Other problems that might be caused by the excessive coughing are pneumos and rib fractures, like cough that bad. Subconjunctival hemorrhage, right? You get the little burst of a blood vessel in your eye. Not too big. Epistaxis is also a possibility. Shock is defined as an inadequate oxygen delivery for your metabolic needs, right? So shock has a number of different issues, or a number of different components. So one is the circulating blood volume. So for the most part, blood volume is about 60 to 80 milliliters per kilogram of body weight. So that's not a lot, right? We talk about how an infant, a 9-pound infant's got about 12 ounces of, of blood. So any small loss of blood can be extremely devastating. That's why if you ever look, you guys are in your hospital rotations, if you're going to L&D and they're taking blood from a child, they will use the smallest little blood collection tubes, okay, because they don't want to take out milliliters of blood because the kid's only got a little bit. Shock will progress very rapidly once the compensatory mechanisms fail. Like you have a little bit more time with adults, right? You're like, oh, we can fix this, we can do this. But once kids start having a deficit, they're just fall right off the face of the earth. So you have to have a high index of suspicion that a child is either ill or has a low circulating blood volume. Maybe there's a level of hemorrhage or there's a level of dehydration, but you need to make sure that you have a very high index of suspicion. We talked about this already a number of times, but children lose a lot of heat to the environment, okay, because they have a very high body surface area, and they can't shiver great. Hypothermia makes resuscitation and drug therapy less effective. That goes across the board, not only just in children, it also goes across the board for adults. Okay, so you always want to make sure that you're keeping your cardiac arrest patients warm. Um, Kids also can just develop hypothermia from a number of other issues. Okay, exposure, but from infection and stuff like that. So you want to make sure that you minimize the number of things affecting them. Metabolic acidosis and respiratory depression. Like we can fix certain parts of this, so keep an eye on it. In regards to cardiac reserve, right? Kids don't have a really cardiac reserve. They can adjust their heart rate. That's it. They can't really impact their contractility. So if a kid is sick or they're in a shock state, they don't have any reserve. They can't deal with shock. They're already dealing or operating at a very high heart rate. To increase it more might be too stressful. They're going to need a lot more metabolic reserves that they don't necessarily have. So you want to keep kids as calm as possible, like calm and relaxed, so that you're not burning, glucose and oxygen stores unnecessarily. Um, Vital signs, right? We don't necessarily take blood pressure on children under 3 years of age, but the level of consciousness is a really good sign. Um, you want to make sure that if you're taking a pulse, right, you might be taking it here in the brachial. Cardiac monitoring is always good. You might not necessarily know what's going on with the child. But bradycardia is one of the more common pre-terminal cardiac arrest rhythms, okay, in children. They'll be tachycardic for a really long time, and then all of a sudden they'll just really bradycardic, and then they go into cardiac arrest. Capillary refill is very effective in what's going on. Vomiting, diarrhea are the primary cause of hypovolemia in children. Next question. Cause of dehydration in children. Vomiting, diarrhea. Your dehydration, right? You can see a profound fluid loss from the vomiting and diarrhea and vomiting. Um, and then because kids don't have a lot of blood volume, they can deteriorate very quickly. Um, the child loses the equivalent of 5% or more of body weight when fluid, cardiac output, and systemic perfusion are seriously compromised. Keep that soda can in mind, right? An infant, 12 ounces of fluid. 5-year-old child, 1 2-liter bottle of fluid. Just keep. Your distributive shock, children can be caused by, these three, which is the same as an adult: septic shock, neurogenic shock, and anaphylactic shock. The difference is that there's more peripheral pooling that goes on. These shock states, the plasma leaks and the blood volume is depleted relatively quickly. Septic children will look very, very ill. Again, please don't forget that neurogenic shock does not present itself the same way as other shocks, right? These are kids who have these are patients who have warm skin, bradycardia, but they'll have a neurological impairment most of the time. The warm skin is going to be beyond the point of the spinal. Anaphylaxis in children is just like anaphylaxis in adults. Antibiotics, food, and insect stings. Insect stings are very, very common. Okay, it's the #1 cause of anaphylaxis, anaphylactic deaths. Heart failure hopefully is less regular in children, or less commonly seen in children than in adults, right? They have squeaky clean hearts. There are some issues that would cause heart failure in children other than congenital heart diseases, which we already talked about. Cardiomyopathy is another thing, right? That the heart starts to narrow. Those are kids who unfortunately will probably end up needing a heart transplant. Myocarditis, which is usually secondary to a viral infection, okay? And again, their heart failure signs and symptoms are going to look very similar to the same signs and symptoms that you adults. It's just rather than it being an 8-year-old, it's an 8-year-old. You know? They might have edema, they might fatigue, but like their fatigue is like during play, like they can't run around and play tag. Okay, a lot of the things that you'd expect a young healthy child to be able to do, they might have difficulty doing. So it's always a possibility. Just keep it back of your mind. This one pops up, this question. Most common dysrhythmias in pediatrics: sinus tach, SVT, bradycardia, and asystole surrounding resuscitation. Clinically significant bradycardia is less than 60 with poor systemic perfusion. Okay, so you have a kid who maybe their heart rate's like, 50 something, and they look pale and cool, and they're just not having a good day. That's clinically significant. You have a kid whose heart rate's 50 and they look fine, less so. Okay, less clinically significant. You have two. You have the types of bradycardias. You have primary, which is like a problem with the heart. Okay, so it might be congenital heart defect or some sort of direct insult to the heart. And then you have secondary bradycardia, which is easier to fix, right? So hypoxia, acidosis, hypotension, hypoglycemia, okay? A lot of those H's and T's that we see in regular cardiac arrests for adults, okay? So you can correct a lot of the secondary bradycardia issues and help your patient. Those algorithms that are always very helpful. Your H's and T's that you're considering. Okay? You'll probably do this more in depth when you do house. Oh, hey, your H's and T's again. PEA, all right, you're looking for the underlying cause. If it is a reversible cause, you should fix it, okay? So finding out why this child has gone into cardiac arrest across the board. You have PEA, BTAC, BFib. You're looking at those H's and T's and you're trying to correct them. All right, SVT. I know we learned in cardiology for adults is like 150 or higher is SVT. Children and infants get a little bit of a boost on that rate. So either for children, it's usually 180 is the threshold, and infants, it's 220. This is the most common non-arrest dysrhythmia seen during childhood. All right. It can cause cardiac instability in infancy, but you have to also remember younger children can maintain those higher heart rates a lot longer than adults can. You're really not treating anything until you see it having a poor perfusion. VTAC and VFib are relatively uncommon in children. The most common time that you'll see VFib is if you have that RNT phenomenon, right? They get hit with a baseball at the wrong time during the cardiac cycle, and they could drop. That'll drop into like a VFib. Most of the time, if you do see VTAC or VFib, it's a cardiac, like a primary cardiac problem, like a insult to the heart in general. There might be, some of your H's and T's that could pop up, but again, remember most of the time that's going to go at SVT. Adenosine might be considered if the rhythm is regular and monomorphic, because SVT, again, is much more common in children than VTAC. So it might just be a very wide SVT if there is a VTAC with a pulse synchronized cardioversion. Algorithms. And you're going to see this much more in depth when you guys do PALS. I like to recommend that no matter what, you should probably, if your child is in cardiac arrest, you should probably transport. There are a collection of children who suffer from serious pre-existing health issues. So those kids have advanced directives, fortunately. But the thing is, especially if it's a toxic emergency, a hypothermia, or even a drowning, prolonged resuscitative measures are, recommended, because will survive a lot longer and potentially less of a logical impact. Even if they, down for a period of time, they might still survive and be okay. So any doubt, just support. Kind of going back to consent, the very beginning of class, right? You should always make sure that if you're treating a minor, that whoever is in charge of that patient's care, guardianship point of view, is being made aware of what's going on, what's being done, and like how the patient's doing. Okay, not only is it just good, communication, it will help calm the parent. Okay, a calm parent means a calm child. You want to do everything in your power to make sure that this child is as stable as possible. You want to have good O2 saturation, have good ventilation. They're responding to whatever treatments that you want to make sure that you're bringing to a pediatric care hospital. Meningitis is very common in young children. I think we talked about this already a little bit, but we're going to recap it a little, right? That nuchal rigidity, that stiffness in the neck, is usually one of the hallmark signs of meningitis. Bacterial meningitis is much more deadly than viral meningitis. Viral meningitis is self-limiting. You might have a child who is, in that 6 months to 2 year realm, has viral meningitis, and they really just kind of present as having they're sick, like flu-like symptoms, right? If it doesn't get that bad. But bacterial meningitis can kill a child within a few days. It can kill an adult within a few days. So any of these signs and symptoms can occur, but again, they are relatively, other than the nuchal rigidity, non-specific for meningitis. It could, a lot of those things could be almost any. Here's your two signs. Koenig's sign. lay a child flat, patient flat, because this also does not just children. You lay a patient flat, leg up, they won't be able to extend their knee at 90 degrees because of the stiffness in the spinal cord. Brudzinski's sign is if you bend their neck forward to their chin, their knees start to bend up also. Again, because of the stiffness in the from the inflammation in the spinal cord. Meningitis also has usually a petechia associated with it, that rash. If you press on it with a glass, like you see in this picture, it will not blanch. It will remain red instead of getting white. So that, you know, have a drinking glass laying around and you check if it's meningitis or not. Hydrocephalus is commonly seen in young children. Basically, there's excessive cerebral spinal fluid that's being produced, and it's not getting out of the brain quickly enough most of the time. You'll see a large head size, eyes getting pushed down, right, because of the pressure on the optic nerves. They, depending on how old they are, it might present with Cushing triad, right, because if their fontanelles have closed, there's nowhere for that extra fluid to go. You might encounter a child who has a hydrocephalus shunt. Okay, so it would be like a little, like they put a drain in and they run it back behind their neck down into their abdomen to get rid of the extra cerebrospinal fluid. Sometimes that shunt can become blocked, okay, or it can become infected. All right, so it's something to keep in mind. You have an older child who has a history of hydrocephalus. That shunt. See, it depending on where it goes, they put it in right under the skin. It goes and drains into the abdomen. So may or may not encounter this, okay, but you might take that little, the part on top right here, there. They use to adjust magnet to adjust the flow. Most common cause of new onset seizures in children is a fever. Okay. Other quick follow-up or quick seconds are head trauma, non-compliance with medication, right? So if a kid already has a history of epilepsy and they don't take their medication right, metabolic disturbances, right? If they happen to have undiagnosed diabetes, you might see seizures. Or any other number of other concerns, metabolic concerns, okay? Most of the time what you're going to see is probably a febrile seizure. Most of the time kids who are less than a year old will experience febrile seizures, but it can go on till about 5 years old. Most of the time they will have that tonic-clonic activity and will be very, very rapid, a very short period of time, and then they will come back to acting normal almost immediately. The problem, or not, yeah, like I said, the problem with febrile seizures is that mom and dad can be doing absolutely everything right. They could be giving them the Motrin and the Tylenol for the fever, you know, every 4 hours. But if that fever overwhelms the NSAIDs, it's how fast the fever rises. It's not that they have a fever. So if you know, they spike a fever all of a sudden, it could cause a seizure. So mom and dad honestly end up being like your bigger patients because they feel awful that their kid's now on the way to the hospital because they think they did something wrong, even if they did everything right. You know, just an underdeveloped hypothalamus in a child that leads to it being so grossly affected by a fever. It's really, again, it's not about how high the fever is, but how fast the fever gets there. And then on the flip side, you don't want to cool this patient off too much either, because when it comes back down, if you cool them off too fast, you can trigger a seizure again. So status epilepticus, okay, 4 to 5 minutes of a seizure or recurring seizures without intervening periods of a consciousness. This is much more serious in a child because you want to make sure that you're stopping the seizure because they need to be oxygenated. Primary care, airway and ventilation support. You want to make sure you check the blood sugar, make sure it's not a concurrent, it's not one of the causes, or that they haven't tanked their blood sugar out and will continue to seize because, you know, they don't have those stores. Cardiac monitoring always important. Benzos are there also. In terms of hypoglycemia, most of the time, it's kids aren't eating enough, or they're eating not eating enough and physically exerting themselves too much, or they might be that they're sick. Illness is usually a common cause of blood sugar derailment. Um, Most of the time, kids with type 1 diabetes, they're still trying to figure out an insulin dose, all right, or they're trying to manage insulin dose appropriately. And again, because kids are very active, kids want to move around a lot, they might have excessive physical activity and not eaten enough and taken their insulin, and their sugar is going to tank. So, on the other side, hyperglycemia is usually the initial symptom of diabetes diagnosis. This one pops up on the state and the remap all the time also. So you'll have a kid who mom says, kid's been fine, maybe a little sick the last couple of days, and now they're hot. They've been, they have the signs of polydipsia, polyphagia, polyuria. They're losing a lot of weight um, because that sugar isn't getting into the cells. So they go into DKA and then the hospital after being treated for hyperglycemic DKA with a new diabetes diagnosis. Diabetic children who have hyperglycemia is usually an insulin issue. Either they're still trying to figure out what their insulin dose should be, or they haven't taken it, or again maybe they've gotten sick. Illness is one of the number one ways that your blood sugar gets kind of derailed, whether or not you are actually a diabetic or not. Blood disorders, right? The same things that you might see adults who have the same things, sickle cell, blood cancers, stuff like that. Um, Persistent bruising is usually a bad sign of some sort of blood cancer. Bleeding for wounds, okay, so right, so maybe they don't have enough of the platelets that they need. Signs of shock, right? Remember, kids still have a lower blood volume, so any of this eating that they are experiencing could also put them over into a shock state really quick. GI issues, if they're bleeding, GI, you want to know when it started. Um, First, you always get a good, especially if the kid's less than 3, get a good maternal um, history. Was the baby premature? Did they spend any time in the NICU? Were they diagnosed with anything? Um, you know, any issues during fetal development, mom, gestational diabetes, stuff like that. So a lot of the time, GI disorders are secondary to that malformation. They cause vomiting. Vomiting is relatively protective. Your body's trying to get rid of toxic materials. Um, I'm sure almost everyone has gotten to the point where you've coughed so hard you've almost vomited. Same thing can happen for kids. Toxic ingestions. Um, Migraines are bad, especially in like the teenage years. They could pop up. Migraines can cause all sorts of different vomiting problems. But then as you move into the adolescent stage, you also want to make sure that you're taking into consideration eating disorders or bulimia. Bleeding, upper and or lower, um, again, always a possibility. Usually, younger children, it's hopefully less serious, but there's always problems that might arise. Um, yeah. Poisoning and toxic exposure, always a possibility. Kids. Um, Unintentional ingestion is a huge cause of preventable death in children. Aspirin and Tylenol in particular. Aspirin is very deadly to young children because it causes Reyes syndrome, Reyes, Reyes, um, because of the acidic. Okay, so aspirin is highly acidic. Tylenol is also a problem. So like they'll give a kid Tylenol for a fever, and then the kid also has a cough, and they'll give them a cough medicine, but the cough medicine also has Tylenol in it. And it's an accidental overdose on the Tylenol because not noticing that there's so much Tylenol in all of the different medications that they're giving them. As kids get older, obviously street drugs and other issues arise, that they might try to overdose on. Young children batteries, especially those little watch batteries, those little disc batteries, are very deadly. They will get stuck in either the esophagus or the airway and burn a hole because of the battery acid. Okay, household cleaning substances, right? You want to make sure that all those things are stored properly. Kids get hurt all the time. Most of the time it's relatively uneventful, like I fell down, went boom, right? They maybe hurt their wrist or broke an ankle or something like that, right? So falls are very common. Motor vehicle crashes are a very high cause of death in children. Most of the time it's due to inappropriate car restraints, right? They keep changing the way that kids should be restrained. Like it initially started, at 1 year old, you can flip them around to being a front facing child seat or whatever, but now they want them to be reverse facing for longer. Like booster seats for younger children, okay? Because cars are not designed for smaller humans like that. And like the neck, the shoulder strap can cause a lot of neck damage for kids. Um, pediatric versus, okay, it could be versus almost anything. Um, right, it could be a car, bicycle, okay, like kid getting thrown, a kid's gonna get hurt. Drowning and submersion are really are very common, okay? And just because a kid was pulled out of a pool and did not necessarily drown doesn't mean that they should still be seen in the ER. They can have a delayed drowning reaction. Penetrating injuries most commonly due to adolescence and more common in the urban areas with accesses to guns and or stabby stabs. Burns, common kind of throughout. Most of the time it's a kid pulls a hot coffee or hot tea or something onto themselves, but it also could be a sign of child abuse, right? Burns from cigarettes. It could just be they touch the hot stove or any other number of things. Child abuse comes in a number of different flavors, right? Physical, sexual, emotional, and/or a combination of all of those, and neglect. So always have a high index of suspicion. Um, we talked about MVAs. So head and neck injuries are very common because that big old pumpkin head and very weak neck muscles. So this is why kids are being put in a rear-facing seat longer so that they don't have that forward motion. A lot of the time, the cervical mobility is higher for younger children as opposed to for adults and older children. They can experience something called an internal decapitation, where they actually the weight of their head pulls their spinal cord up and out of their out of the vertebrae. So it can be resolved, but it's also can be very deadly. A lot of times, kids will have concussions from their big old pumpkin head. Excuse me, flopping around. Excuse me. But at the same time, because the brain, like the skull and the brain, are more pliable, increased intracranial pressure not necessarily affect them as quickly, but it's still an issue, and this might take longer for you to notice the signs and symptoms. Same signs and symptoms for traumatic brain injury that in children as you see in adults. But if they're very young, you might have to modify the GCS, right? If they can't answer questions appropriately because they don't really haven't grasped language yet. Abnormal posturing, asymmetrical pupils. Okay, again, this is the same thing that you'd see in adults, but you really want to be checking is the bulging fontanelles in infants. Chest injuries. Very flexible chest wall, right? So they might have damage to the ribs and stuff that you won't necessarily see. Because of the small lungs, tension pneumothorax is much more deadly. Flail segments are rare because of those flexible lungs, but if there is a possibility of a flail segment, Child abuse should always be high on your list of suspicions. Cardiac tamponade, right? You see that in adults, you get that muffled chest, that muffled heart sounds. Most of the time, kids will just present with hypertension. We talked about this. This is a green stick fracture. See how that bone has bent but not fully broken? That's what you see in kids who have like it's like a bendy piece of wood. Okay. Most of the time, kids will fall and they'll like hurt themselves. It's very common, right? They fall off the swing set, the monkey bars, right? We don't necessarily think that it's immediately child abuse, but um, femur fractures, in particular, should be considered, you know, child abuse should be considered in there. You're not going to do anything different for broken bones in a child. Right? You're going to split and control bleeding. Maybe put on an ice pack. Talk about trauma more in the next. Burns, we talked about this, right? This is the most common cause of kids, them pulling hot liquid onto themselves, those scalding splash burns. Um, Electrical burns are also a possibility, right? They stuck a fork in that electrical socket, but you should also make sure that you're checking for musculoskeletal size injuries. If the airway is involved, the air that might swell up rapidly. So you might, if you do have to tube these kids, you might have to use a smaller ET. So some differences in the management for trauma, right? Especially the younger children, you want to put them in that sniffing position, which isn't going to be back as much as you do for adults. Um, but you're going to make kind of primarily stick with your BLS procedures, right? You're not going to be doing a lot of, IVs and meds and stuff like that. You're tubing and all that jazz. Go to the hospital. Okay, go to the hospital. Um, Biomobile restriction again. You don't do a lot of these things anymore. You're gonna get a pediatric collar on the kid. That's fantastic. Um, even if you don't have as high of an index of suspicion, you should have a lower threshold, just a lower threshold for putting a collar on a child, because if they have neck pain, it's more significant. We do restriction, right? We're not going to necessarily strap them down to the board, unless there's a reason that we have to. You might have to improvise with towels and blanket rolls to stabilize a young child. If a child is in a car seat, do not remove them from the car seat unless the car seat is absolutely destroyed. Okay. If the car seat is demolished, you should be highly suspicious that the child has also suffered a significant trauma. We don't do IVs on kids all that often, right? Not only just from a perspective of, we don't see pediatric patients all that much. We don't have a lot of time to practice doing pediatric IVs, so don't waste time trying to practice on that kid who's probably a critical patient. Pain relief is a priority, but there's a number of ways that you can administer pain meds intranasally. Fentanyl is intranasal, so you can provide pain relief for that child that way. Pediatric trauma score helps also in determining how badly injured a child is. So you want to make sure, you're assessing your kid, the child appropriately. So SIDS. SIDS is usually a sudden and unexpected death of a child less than 1 to 2 years old. Okay, most of the time, SIDS will occur between 2 and 4 months. That's kind of the primary age range where you see it spike. Um, it cannot be predicted or prevented. They really have no idea what the cause of SIDS is. Sometimes they think that positioning during sleep might be a factor, where the airway gets closed off unexpectedly. Most of the time, unfortunately, these children are not found until the next morning, and they have already gone into signs of obvious death, lividity, and rigor mortis. Sometimes you might end up working a SIDS baby to the hospital because it's just good for the parents. Child abuse and neglect. Um, I feel like we talk about this a lot, but kids will have odd behaviors. Okay, or withdrawn, or they're going to be super hyperactive. Um, a lot of the times, the problems is that the adult cannot manage their own stress. They take it out on their child. It could be physical, sexual, it could be emotional, issues. But most of the time, kids who are at increased risk might have medical issues that require attention, who might be a little too very high level of intellectual ability that is like a threat to the parents. Very young children who can't protect themselves, stepchild or adopted child. Okay, so it's either end of the range of the spectrum for what the child might present as, but then you seem to have the same pattern of issues, unexplained injuries, burns and bruises, various stages of healing, something that might be, indicative of an intentional um, injury. Okay, like kids aren't going to start putting out threats on themselves. Um, and then also how the parent reacts to the child. Okay, the parent might be let an injury linger. And then on the same token, like how the child responds to the parent. Like if the parent, like the child doesn't look to that parent for comfort when they're injured. Um, any child who has too much knowledge about sex is probably being sexually abused. Okay, there's a number of different clues that you can. Here's some of the physical findings that you might encounter um, for a child who is being abused, neglected. Um, right, you might have subdural hematomas, delays in medical care, vague history or history that doesn't match up to either the injury or the child's account. Okay, right. So, especially as the child gets older, they're going to be able to provide you a certain level of information regarding an incident. The child will be most of the time relatively accurate. They're not going to lie. A lot of kids aren't going to lie about how they got hurt because it's not like they don't know that they're going to they don't think they're getting in trouble for it. Okay. Um. What else? Current vomiting. Okay. Any damage or injuries to the genitalia. Okay. Um. Child less than 12. Bleeding from the rectum. Okay. Any of those things, right, are very good signs of sexual abuse. Even if the child has, as I said, a little too much knowledge about sex and what's involved in sex. Children with special needs are also at a very high risk of being children who are abused. However, hopefully most of the time, families. Tracheostomy tubes. A lot of the time, parents will be the experts in this. Sometimes the tracheostomy tube will dislodge. Okay, it might have a leak. A lot of the times when they're younger, they don't necessarily have a cuff. Um, it could be infected around the site. It could have some complications when they're replacing the tube, because a lot of times they'll teach mom and dad how to replace the tracheostomy tube, and they'll teach them how to suction and all that other stuff. In order to even bring this child home from the hospital, mom and dad need to go through a significant amount of training. Okay, they're not just going to be like, well, we're going to get you a nurse and that's it. Like, no, mom and dad get put through not only on the tracheostomy tubes and stuff like that, but also the vents. If for some reason you do have to bring this child to have the tracheostomy tube placed, you should know what brand, size, and if it's a cuffed or uncuffed tube. Okay, even when you're going and dealing with adults, right? If you're ever doing the transport life and you're bringing a patient from a nursing home to get a tracheostomy tube replaced, brand, the size, and the cuff or uncuff. Okay, because if they have one brand and the hospital doesn't have it, they have to do a different size. They might have to like keep them longer than anticipated. Home ventilators, a lot of the time, like these kids will be on they have their own setting. You'll see the LTV vents are very commonly used at home. Um, they have their settings. It gives them a number of different things. Like there's options like you can have a sigh on there because that's a very natural, normal human response. is a sigh or a yawn because it just helps recruit more alveoli. Um, if you have to transport a child who's on a ventilator, mom or dad or the nurse needs responsibility for the ventilator. Okay? You are not trained to, period. Okay? Don't take that liability on yourself. So that means that if you're transferring that child, that mom and dad's like, oh, like the ventilator's all there. So if it makes an alarm or it beeps or it boops or whatever, that's their responsibility to take care of it. It's much more comfortable for the child to be on the ventilator, and this goes for the adults also, to be on their ventilator rather than switching them to a completely different mechanics. It's not as comfortable. A number of complications. It could be an airway obstruction. Especially if a kid gets dehydrated or a little bit, it might end up with what's called a mucus plug. Okay, because they just get a little junky up in there. The machine or the alarm might have the machine might alarm. Um, so central lines, you are not allowed to access a central line. Um, it comes in a number of different settings. You might have a singular, you might have a trilumen. A lot of kids who might be chronic illness might have a central line. Number of different things. Most of the time, local infections are probably the most common that you're going to see. A crack line could also be a possibility where they might be bleeding from the line itself or bleeding from the obstruction. You're not going to fix the obstruction. You're going to bring them to the hospital to have the obstruction addressed. There's some children who might require a G tube. Okay, if they're having a number of stomach issues or swallowing issues, um, they move from a gastric tube to a gastronomy tube that becomes permanent, surgically emplaced. The G tube is not too bad. It just goes right through stomach. It's usually G tube. That's it. All right. Thoughts, questions, concerns? Oh, all right. Cool. Well, that's the lecture for today. Hope you all have a lovely day. Thoughts or questions? I'm going to stop the recording.